In part two, I'd like to go through the basic pathology of the appendix. Firstly, there's appendicolith, which usually results in appendicitis, but not always. Appendicitis with or without appendicolith, mucocele of the appendix, or the commonest appendiceal tumours. Occasionally, an appendicolith can be so characteristic that a diagnosis of appendicitis in the right clinical setting can be made. However, when there is any doubt clinically about the diagnosis, further imaging is required. On this ultrasound examination, we have the rectus muscle just below the layers of the skin, and here you can clearly see arrowed an appendicolith with posterior acoustic shadowing. The appendiceal wall is clearly thickened. In most texts, it's claimed that from outer wall to outer wall should be no thicker than 6 millimeters, and this clearly exceeds that. This is an undoubted case with wall thickening, luminal fluid, and appendicolith of acute appendicitis. Here we have a case of appendicitis on ultrasound without an appendicolith. Again, the arrows show areas of the appendix that are clearly thick-walled, contain luminal fluid, and you can see this rather echo-bright inflamed fat surrounding the inflamed appendix. Again, a clear case of acute appendicitis. Here we have an MR scan. These are T2-weighted sequences. They're very rapid and they do not require contrast. You'll also notice that this is a pregnant lady, so is particularly appropriate in her case to avoid CT. The appendix shows mild wall thickening, some luminal fluid, and some mild inflammation around the appendix. Again, undoubtedly early acute appendicitis. And on this CT scan, similar findings. The wall of the appendix is not particularly thickened, but because of the luminal fluid, the outer to outer wall would exceed 6 millimeters here. But just the way this appendix stands out with an extremely mild amount of inflammation confirms early acute appendicitis. Here we cover mucocele of the appendix. Mucoceles are normally caused by a benign mucin-secreting cystadenomas, but they can be caused by obstruction of the appendix, usually due to an appendicolith, but as in this case, and very rarely, torsion of the appendix can cause a mucocele distally. The characteristic appearance of mucocele, in this case not non-obstructive, is calcification in the wall, as these can be chronic conditions by benign mucin-secreting cystadenomas. Here we have a large mucocele, and one notes that the calcification is somewhat elevated in the wall, making one worry that there may be some level of low-grade malignancy in this wall. This mucocele, on its radiological appearances, really would need to come out and be histologically sectioned. The process of calcification can go on to the extent, as in these cases, where it becomes what's known as a porcelain appendix. Be very careful not to confuse this with a low-lying porcelain gallbladder. These are mimics of mucocele. I draw your attention particularly to cystic ovarian neoplasm, right hydrosalpinx, and Meckel's diverticulum. But again, so long as you trace carefully where all these structures originate from, they should not be confused with mucocele of the appendix. Here is an obstructive mucocele. We saw one earlier caused by torsion. This is caused by an appendicolith, and you can see that it has also caused some inflammation around, suggesting perforation. When we come to the malignant appendiceal neoplasms, the commonest is a neuroendocrine tumour, and these are carcinoids. They characteristically create a desmoplastic reaction around them, and you can see the effect that this primary appendiceal carcinoid has on the nearby ileum. This is a malignant mucinous secreting cystadenocarcinoma. Very worrisome tumours, as they tend to perforate and epithelial cells then track, produce mucin where they locate, and we can see here that there's mucin production above the liver, below the diaphragm, showing that this has indeed dissected and tracked. And this process, if it goes on further, you can see little blobs of mucin where epithelial cells have tracked. When this process becomes extensive, it can result in pseudomyxoma peritonei. This is a very rare tumour, which is a simple adenocarcinoma, of which there are various types. The main reason for showing these is you must not confuse these with appendicitis. The surgeon needs to know that you suspect that this is a carcinoma,